The provision of timely and appropriate pre-hospital care has saved countless lives in the past 25 years. Emergency medical technicians are skilled and dedicated professionals. The Department of Transportation's EMT curriculum is a national standard which defines minimum skills for EMTs. The National Registry of EMTs offers an examination based on the DOT curriculum to evaluate competency in those skills. This program, Pass EMT, reviews and demonstrates the National Registry Basic Level Exam. Whether you plan to become nationally registered or not, this lesson offers a concise review of skills which every EMT in the country must know. The goal of this video is to help you evaluate yourself and identify specific areas for your further study. The National Registry Basic Level Examination consists of 5 practical skill stations and a written examination. 2 of the stations are scenario-based and require integration of various skills. These are patient assessment and management and cardiac arrest management. 2 of the stations are strictly skill-based. These are spinal immobilization of the seated patient and bag valve mask apneic patient with pulse. In the random skills verification station, you will be tested on one of the following 8 skills: long bone fracture immobilization, joint dislocation immobilization, traction splinting, bleeding wounds shock, spinal immobilization of the lying patient, oropharyngeal and nasopharyngeal airways, mouth to mask with supplemental oxygen, and supplemental oxygen administration. We will review each station and the instructions that you will receive when you report to that station. The skills will be demonstrated and essential points for successful completion will be offered. In the exam, you will go through the 5 stations in a random order. This exam process is not a teaching or training session. It is a verification of your skills and knowledge. One of the most challenging situations that the EMT faces in the field is the critically injured trauma patient. A combination of skills and knowledge must be combined appropriately for effective patient management during the initial encounter and transport to the healthcare facility. The Patient Assessment and Management Station is designed to evaluate your ability to integrate the assessment, examination, and management skills effectively and efficiently on a victim with multi-system trauma. There is a skill sheet which lists the requirements of each station. In this station, you are not required to complete the assessment steps in the exact order that they appear on the skills sheet. Also, the scenarios that are used in this video are not necessarily the same scenarios that will be used in your exam. The following directions will be read to you. This station is designed to test your ability to perform a primary and secondary assessment and voice treat all conditions and injuries discovered. You must conduct your assessment as you would in the field, including communication with your patient. As you approach the patient, you should assume the scene is clear of safety hazards. You may remove the patient's clothing down to shorts or swimsuit if you feel it is necessary. As you conduct your survey, you should state everything you are assessing. Clinical information not obtainable by visual or physical inspection, for example blood pressure, will be given to you after you demonstrate how you would normally gain that information. You may assume that you have 2 EMTs working with you and that they are correctly carrying out the verbal treatments you indicate. I will acknowledge your treatments and may ask you for additional information if clarification is needed. You have 10 minutes to complete this skill station. Do you have any questions? The evaluator will read a scenario to you.
You are called to the scene of a bar fight. You arrive on the scene and you find your patient supine outside of the bar. The police are on the scene and the scene is considered safe.
Okay. My partners and I are going to come in using the appropriate infection control procedures. I'm approaching the patient. I'm going to establish inline stabilization of the C-spine. Sir, can you hear me? Sir, can you hear me? Is there any response?
Your patient does not respond.
Okay, and I'm going to open up the airway using the modified jaw thrust. I notice that there's blood about the mouth. Do I hear anything?
Yes, you hear some gurgling and you also see blood in the mouth.
Okay, I'm going to have my partner suction the patient right now, and then I'm going to have my other partner assume the C-spine stabilization of the patient.
Okay, your partner suctions out the mouth and your other partner assumes inline immobilization. The airway is clear at this time.
Okay.
A key point to remember in most stations is to state that you will observe infection control precautions. It is generally helpful to begin the station wearing gloves. The candidate first stabilized the C-spine and opened the airway with a modified jaw thrust. In assessing the airway, he simultaneously determined that the patient was unconscious and noticed blood around the mouth. Upon learning that there were gurgling sounds, the candidate directed the treatment of suctioning. With C-spine stabilization managed by an assistant, he progressed to the next portion of the assessment, breathing.
I'm going to come down and I'm going to check for breathing, and as I work my way down, I'm going to check the neck. Do I have any tracheal deviation?
There is no tracheal deviation.
Okay. External jugular vein distension?
Jugular veins are flat.
Okay. Is there any tracheal tugging or anything like that?
There's
intercostal retraction?
no tracheal tugging or intercostal retractions noted.
All right. I'm going to open up the shirt to expose the chest. How is my breathing? How is the depth and rate of breathing?
The depth is shallow. The rate is approximately 32 times per minute.
Okay. At this point, I'm going to take over his breathing with a bag valve mask, have my partner do that with 100% oxygen, 10 to 15 liters, with a reservoir attached. How is the air moving?
Okay, your partner assumes bag valve mask ventilation with oxygen and states that the compliance is good.
Okay. I'm going to inspect the chest right now. I find that there's a hole here, so I'm putting my hand over the top of it, and I'm looking on the other side. I will cover this with a non-porous dressing and leave one side up. I'm going to auscultate the lung sounds at this point.
Okay, your partner covers the open wound with a non-porous dressing.
Okay. I'm auscultating both sides of the chest. Okay, what do I hear?
You hear decreased breath sounds on the right, good breath sounds on the left.
Okay. I'm going to do a quick assessment of the chest to make sure that he's got equal expansion.
Okay, the chest is rising and falling symmetrically.
Okay.
The candidate's breathing assessment included checking the neck for tracheal deviation, jugular vein distension, and tracheal tugging. He exposed the chest and inquired about the depth and rate of breathing. He directed bag valve mask ventilation with 100% oxygen run at 10 to 15 liters with a reservoir. The evaluator mentioned there was good compliance. Upon discovering the open wound, he managed it with a non-porous dressing and then auscultated for lung sounds. Finally, he assessed the chest for equal expansion. Next, he will assess circulation.
All right, now I'm going to check for a pulse, and I'm also looking for a quick scan for major hemorrhage. Do I find any major bleeding?
There is no major bleeding noted, and the radial pulse is absent.
Okay. I'm going to check for the carotid pulse. Do I have a carotid pulse?
Carotid pulse is present.
Okay. What about my skin temperature and texture?
The skin is pale, cool, and clammy.
Okay. I suspect that the patient is in shock. I'm going to take a quick blood pressure, and before I do that, I'm going to assess, do a quick secondary on his arm so I don't cause any further injury.
Nothing
if
is
he
noted.
has. Okay, what's my blood pressure?
The blood pressure is 72/50.
Okay, blood pressure is 72/50, so I'm going to apply the pneumatic anti-shock garment. Before I do that, I'm going to do a quick secondary exam of everything that the anti-shock garment is going to expose.
After assessing and managing airway and breathing, the candidate moved to circulation. He assessed the vital signs by taking radial and carotid pulses. He checked skin color, temperature, and texture. He measured blood pressure and scanned the body for signs of bleeding. He indicated that he would apply the PASG. You must follow your local protocols when considering or applying the PASG. This candidate chose to apply it. In addition to assessing circulation, the tasks to be completed in the primary survey section are to assess disability with AVPU, neurological functions in the extremities, and assess the eyes, whether the pupils are equal and respond to light. Be sure to expose the patient adequately for your assessment. Finally, a key point is to make the decision whether to transport or to continue with a full secondary survey on scene. The candidate will now continue by checking the areas to be covered by the PASG.
Okay, I'm going to assess the abdomen, pressing in. What do I find? Anything?
Okay, abdomen soft. There's no rigidity or tenderness noted.
Okay, I'm checking the pelvis, pushing down, compressing the wings.
Pelvis is stable.
Okay, I'm going to expose the extremities here, cut the pant legs off. I'm going to assess the legs. And I notice that there's bruising. Do I find deformity?
Yes, there is deformity and there is some edema.
Okay. I'm going to come down and check for distal pulses and nerve function by pinching it. What do I find?
The distal pulse is absent and the patient does not respond to the pinch.
Okay, I'm going to have my partner stabilize that potential injury to the leg, and then I'm going to come over and do an assessment of the other leg. Okay.
Okay, nothing noted.
Okay, I'm checking for pulses, and I'm going to pinch. Do I find any pulses down here, distal pulses?
The pulse is
On the right
absent and the patient does not respond to a pinch.
Okay. All right, at this point, we're going to come up and we're going to apply a cervical collar, and before I do that, I'm going to palpate the cervical spine. Do I find any deformity or any thing worth noting?
Nothing noted to the cervical spine.
Okay, my partner applied the cervical collar. Now we're going to log roll this patient up. Before I do that, I'm going to do a quick check of the other extremity.
Be prepared to verbalize your log roll technique.
Nothing noted.
Pulse is over here. Okay.
Pulse is absent.
All right, we're going to log roll the patient up.
Okay, your patient will assist you in the log roll.
Okay, and we're going to apply the backboard with the pneumatic anti-shock garment laid out over the top. Okay, at this point, I'm going to check the back of his head to see if there's any deformity or bleeding. Do I note anything?
Nothing noted.
Okay, I'm coming down. I'm checking his back. Do I find anything? Palpating along, and I'm inspecting. I see some bruising here. Do I find any deformity of his back?
No other deformities noted.
Okay, how about of his buttocks? Do I find any bleeding or deformity or anything?
Nothing noted.
Okay, I'm coming down the back of the legs, reassessing again. Do I find anything?
Nothing noted to the lower extremities.
Okay, and we're going to log roll them back onto the anti-shock garment and wrap those around and begin to inflate the anti-shock garment. And I'm going to continue inflating until I hear the Velcro crackling or until the air exhausts out the exhaust valves. What kind of blood pressure do I get now?
Your pressure at this time is 86/52.
Okay. We're going to go ahead and further immobilize his C-spine to the full backboard, and we're going to move the patient to the ambulance and start transporting to the hospital.
Okay, you're in transport at this time.
Okay, at this point, I'm going to go ahead and do a complete secondary exam of the patient. I'm going to start at the head and work my way down.
So far, we've demonstrated the typical dialogue which occurs between candidate and examiner. With the transport decision having been made, the candidate is then required to complete a full secondary survey. Since the PASG was applied, the candidate already assessed and managed conditions found on the areas the PASG would cover.
I'm coming around.
The secondary survey is a head-to-foot assessment, as shown in this list. The candidate must inspect the scalp, ears, eyes, and face, including the oral and nasal areas. The neck was assessed before the C-collar was applied. The chest must be inspected, palpated, and auscultated. The abdomen and pelvic areas were assessed before the PASG was applied. The extremities must be inspected with assessment of pulses, sensory and motor activities. Finally, the thorax and lumbar areas must be assessed. Fractures and secondary wounds must be managed appropriately. Key points for successful completion of this station are to first, immediately establish and maintain spinal precautions. Locate, evaluate, and manage all conditions which compromise the airway, breathing, and circulation before attending to other injuries. Provide a high concentration of oxygen if appropriate. Differentiate patients needing immediate transportation from those needing continued scene survey. Transport the patient within the 10-minute time limit. Finally, be sure to specify transportation early for any critically injured trauma patient. Now that we have demonstrated the patient assessment and management station, we will continue with the cardiac arrest management station. In communities where a large segment of the public is trained in CPR, and the emergency medical services are able to quickly respond to cardiac emergencies, the survival from cardiac arrest is improved dramatically. The EMT's ability to provide appropriate and timely emergency cardiac care is one of the most important links in the chain of survival. The cardiac arrest management station has 4 principal phases: assessment, transition, integration, and transportation. It combines patient and scene management skills. The following directions will be read to you. This station is designed to test your ability to manage a pre-hospital cardiac arrest by integrating CPR skills, airway adjuncts, and patient scene management skills. There will be an EMT assistant in this station. The EMT assistant will only do as you instruct him to do, and you are responsible for directing his actions. As you arrive on the scene, you will encounter a patient in cardiac arrest. A first responder will be present performing one rescuer CPR. You must immediately establish control of the scene and effectively transition to 2 rescuer CPR using adjunctive equipment. You may not delegate this action to the EMT assistant. At some point in this procedure, the evaluator will indicate a need for suction during CPR. You will be evaluated on your ability to accommodate this situation. Finally, you will be required to prepare for transportation to the ambulance. You may use any supplies in the room. You have 10 minutes to complete this skill station. Do you have any questions?
No. I'll take infection control precautions by wearing gloves, and so will my assistants.
1 and 2 and 3 and 4 and 5.
I'll check the effectiveness of compressions. There is a pulse generated with compressions. How long has the patient been in cardiac arrest?
5 minutes.
I'll check effectiveness of ventilations, good rise and fall of the chest. How long has CPR been in progress?
3 minutes.
Please stop CPR. Is there a spontaneous return of pulse?
No, there isn't.
Please continue to rescue or CPR. I'll prepare my airway adjuncts, bag valve mask, hooked up to the oxygen. I will ventilate with 100% oxygen at 15 liters per minute. I will insert an oral pharyngeal airway. I will measure this from the tip of the mouth to the corner of the jaw.
The first 2 sections of this station are assessment and transition. Take or verbalize infection control precautions. Check effectiveness of the CPR in progress by palpating whether there is a pulse with compressions, and then whether the chest is rising with ventilation. Stop CPR and verify the absence of a spontaneous pulse. Gather information on arrest events, such as time of arrest and time of CPR. In the transition phase, direct resumption of CPR and prepare your airway and ventilation adjuncts. Now we'll continue with the 2 remaining phases, integration and transportation.
After this ventilation, I will take over. I will insert the airway and continue with ventilations.
You notice the patient has regurgitated.
I would immediately pull away the BVM and suction the airway, and then ventilate, continue with compressions. We will reassess spontaneous return of pulse and respirations every few minutes.
2 minutes have elapsed.
Okay, stop CPR. Is there a spontaneous return of pulse?
There is no pulse.
Continue with CPR. We will continue CPR while the first responder gets the immobilization device. We will log roll the patient after the next ventilation. The first responder can secure the straps.
In the integration phase, you must verbalize suctioning when necessary. Measure the proper sized OP airway and verbalize its insertion. After initial ventilations have begun with an adjunct such as the pocket mask, connect supplemental oxygen and have the patient ventilated with a BVM. CPR must be continued with less than 20 seconds of interruption, and you must perform 2 operators CPR with an assistant. The patient and effectiveness of CPR must be reevaluated. Finally, in the transportation phase, a transportation device must be prepared, and the patient must be moved to a rigid device with less than 30 seconds interruption of CPR. The patient must be secured for transport. Key points for successful completion of this station are to verify the absence of a spontaneous pulse, maintain CPR within time limits while you evaluate and move the patient, ventilate with high concentration oxygen, direct the performance of CPR to standards, and assure performance of CPR on a firm surface. Now that we have demonstrated the 2 integration stations, patient assessment management and cardiac arrest management, we will continue with the 2 skills-based stations, spinal immobilization of the seated patient and bag valve mask apneic patient with pulse. One of the most tragic traumatic injuries is a spinal cord injury. Fortunately, the immobilization of patients before transportation significantly decreases the likelihood that a patient with a spinal injury will suffer a lifelong catastrophic disability. The next station that we will review is spinal immobilization of the seated patient. These directions will be read to you. This station is designed to test your ability to provide spinal immobilization on a patient using a half-spine immobilization device. You arrive on the scene with an EMT assistant. The scene is safe and there is only one patient. The assistant EMT has completed the primary survey and no condition was found in the primary survey requiring intervention. For the purpose of this station, the patient's vital signs remain stable. You are required to treat the specific isolated problem of an unstable spine using a half-spine immobilization device. You are responsible for directing the actions of the EMT assistant. Transferring the patient to the long spine board should be accomplished verbally. You may use any equipment available in this room. You have 10 minutes to complete this skill station. Do you have any questions?
You may begin.
Okay. Derek, I need you to immobilize the patient's head and hold that throughout. Hi, my name's Tom. I'm going to put a cervical collar on you and a short spine board, okay? First, I just want to check and see if you have some pulse and motor function and circulation in your extremities, okay? Checking for a distal pulse. Is there one present?
Yes.
Okay, is he able to wiggle his fingers?
Yes.
Okay, can you feel me touching you?
Yes.
Okay, on the other extremity?
Yes.
Okay, wiggle his fingers?
Yes.
Feels me touching him?
Yes.
Okay. Lower extremity on the right?
Yes.
Pulse?
Yes.
Able to wiggle his toes?
Yes.
Okay, you can feel me touching him?
Yes.
Okay, on the left?
Yes.
Wiggle the toes?
Yes.
And feels me touching him?
Yes.
Okay. Now what we're going to do is put a collar on you. These are a little uncomfortable. First I need to size it. Okay. And they're about a 3-finger collar. This will be a little uncomfortable, but it's a necessary thing. Okay. Next thing we're going to do is move you forward. And I'm just going to slide my hand on your back. Okay, whenever you're ready, Derek, we'll go on your call.
On 3, 1, 2, 3.
Good. Okay. Next, we'll place the device behind the patient. I'm going to secure the device to the patient's torso first. Put the middle strap on.
There are many strapping techniques, all of which are defendable and have advantages. The only consistent rules in strapping are to secure the torso before the head and not to secure straps so tight that they may interfere with breathing. Any order of strapping that achieves these objectives is acceptable. You have plenty of time in this station, so go slowly and be careful not to move the patient unnecessarily during the procedure. The first half of the skills are to take or verbalize infection control precautions, direct the assistant to maintain the head in a neutral inline position, and maintain manual immobilization of the head. Assess motor and sensory functions and distal circulation in all extremities. Next, size and apply the extrication collar. The immobilization device, in this case a KED, was positioned and secured to the patient's torso. Now we'll continue through the completion of the station.
Need to put a little bit of padding behind your neck. Okay. Make sure this is up in the axilla before we secure the head. Okay. The strap on his head. One under the chin. Okay. Just want to check his pulse, motor, and sensation again. You have a pulse.
Yes.
Wiggle his fingers.
Yes.
Feel me touching him.
Mm-hmm.
On the left.
Yes.
Wiggle your fingers.
Yes.
Feel me touching.
Yes.
Lower extremity.
Yes.
Pulse. Wiggle his toes.
Yes.
Feel me touching.
Yes.
Left.
Yes.
Wiggle his toes.
Yes.
Feels me touching.
Yes.
Okay. We would then move the patient to the long backboard.
Okay.
And once he's secured to the backboard, we would reassess distal pulse, motor, and sensation again. Right your side.
Right.
Pulse.
Yes.
Wiggle his fingers.
Yes.
Feels me touching.
Yes.
The station was completed with the evaluation of the torso fixation of the KED, the evaluation and application of padding behind the patient's head, and the verbalization of moving the patient to the longboard. Finally, motor and sensory functions and distal circulation in the extremities were reassessed.
The BVM.
We'll now continue with the final
Tubing to the
mandatory
BVM.
station, bag valve mask apneic patient with pulse, before
the
moving
oxygen
on to the
15.
random skills section.
But that's a bonus.
The ability to quickly manage the airway and ventilate a patient is one of the most important aspects of pre-hospital medicine. Proper use of airway adjuncts and the bag valve mask is a vital component of saving lives in the pre-hospital environment.
His respiratory lights.
The airway oxygen ventilation station is designed to evaluate your ability to initiate and continue effective ventilation of an apneic patient using a bag valve mask. As you begin this station, the following directions will be read to you. This station is designed to test your ability to ventilate a patient using a bag valve mask. As you enter the station, you will find an apneic patient with a palpable central pulse. There are no bystanders, and artificial ventilation has not been initiated. The only patient management required is ventilatory support using a bag valve mask. You must initially ventilate the patient for a minimum of 30 seconds and an additional 30 seconds once high-flow oxygen is connected to the bag valve mask. You will be evaluated on the appropriateness of ventilator volumes. You may use only the equipment available in this room. You have 5 minutes to complete this procedure. Do you have any questions?
No, I don't. I have gloves on for universal precautions. I'll approach the patient using a head tilt chin lift to open the airway, insert an oral airway, and begin ventilating the patient. Now that at least 30 seconds have gone by, I'll attach the tubing to the oxygen, attach the reservoir to the BVM, tubing to the BVM, turn the oxygen on to 15, and continue ventilating for at least 30 seconds. I've now completed this station.
Thank you.
The steps of this station are to take infection control precautions, verbalize opening the airway and inserting an adjunct, and selecting the appropriate mask for the BVM. You must ventilate the patient at no less than 800 milliliters of volume and continue for 30 seconds. Next, connect the reservoir and oxygen, adjust the flow rate to 12 liters per minute or greater, and resume ventilation for another 30 seconds. Remember not to interrupt ventilations for more than 20 seconds and to allow for adequate exhalations. Now that we have reviewed the 4 mandatory stations, we will conclude with a review of the random skills station, which can be any one of 8 skills. These include long bone fracture immobilization, joint dislocation immobilization, traction splinting, bleeding wounds and shock, spinal immobilization of the lying patient, oropharyngeal nasopharyngeal airways, mouth to mask with supplemental oxygen, and supplemental oxygen administration. This program assumes that you have learned these procedures. Our purpose in the remainder of this lesson is not to teach the step-by-step process of each skill. Rather, we will emphasize principal elements and offer reminders for the successful completion of each. With the exception of the bleeding wounds and shock station, the random skills stations focus on isolated injuries or conditions and grant you the fact that the scene is safe. The long bone fracture immobilization station is designed to evaluate your ability to immobilize a non-angulated, closed, long bone fracture using a rigid splint. You may be presented with a fracture of the radius, ulna, humerus, tibia, or fibula. You will have 5 minutes to complete this skill.
I have gloves on. My partner is going to hold manual stabilization of his forearm. Does he have a distal pulse?
Yes, he does.
Is capillary flow less than 2 seconds?
It is.
Is he able to move his fingers and squeeze my hand?
Yes, he is.
Okay. And is he able to feel my fingers?
He does.
Okay. I'm just going to use a padded board splint to initially immobilize the arm. I'm going to put the hand in a position of function. There's really no gaps in there to fill into. I'll just use the roll of cling to immobilize. Is the fracture mid-shaft?
It is.
The progression of this station is to take or verbalize infection control precautions, direct application of manual stabilization, assess motor and sensory functions, and distal circulation. Measure the splint and apply it. Joints above and below the fracture must be immobilized. After completing the application of the splint, the candidate reassessed motor and sensory functions and distal circulation. He then secured the arm to the trunk with the sling and swath. The hand had already been immobilized in the position of function. Finally, after applying the sling and swath, he completed the station by reassessing motor and sensory functions and distal circulation. The next station that we will review is joint dislocation. This station will evaluate your ability to immobilize a shoulder dislocation properly using a sling and swath.
Both my EMT assistant and I are observing universal precautions. Could you manually stabilize that position that it's found? Thank you. I have a radial pulse.
There's a normal radial pulse.
Thank you. Can you squeeze my finger? Thank you. Feel me touching you here?
Yes.
Okay. Capillary read feels good?
Yes.
Okay. What we're going to do now is sling and swath the injury.
The candidate places a sling on the patient. He inserts padding beneath the arm to help immobilize the joint in the position found.
I'm padding all the knots.
He will also place padding behind the neck where he ties the sling.
Just going to use the swath to secure the arm.
With the application of a swath, the bones above and below the shoulder joint are immobilized. Again, padding will be placed where the knot is tied in the swath. The station concludes with a reassessment of motor and sensory functions and distal circulation.
Feel me touching you here and here?
To assure successful completion of this station, be sure to immobilize above and below the joint, provide support so that the joint doesn't bear weight, and assess motor and sensory functions and distal circulation before and after splinting. The last splinting station that we will review is traction splinting. This station is designed to evaluate your ability to immobilize a closed, non-angulated mid-shaft femur fracture using a traction splint. You have 10 minutes to complete this station.
At this time, I'd get my assistant to come over and add some gentle inline traction.
The principal steps of traction splinting are to direct manual stabilization of the leg and to apply gentle manual traction. Assess motor and sensory functions and distal circulation.
Sir, can you feel me touching your foot down here?
Yes, I can.
You can adjust the splint to the proper length by placing it next to the uninjured leg. Remember, the splint should extend from the ischial tuberosity to 6 to 10 inches beyond the foot.
Just adjusting my straps.
When the splint is placed next to the injured leg, remember to prepare and position the straps. Be sure that a strap will not go over the knee or the fracture. Position the splint beneath the injured leg. Secure the ischial strap first.
Slide this up into place.
Next, apply the ankle hitch as the assistant maintains gentle traction and connect it to the end of the splint. Apply mechanical traction until it provides relief to the patient. Finalize the position of and secure the support straps. Re-evaluate the proximal and distal securing devices.
Secure.
Reassess motor and sensory functions and distal circulation.
Down here?
To complete the station, you will verbalize the securing of the torso to the longboard to immobilize the hip, and securing the splint to the longboard to prevent movement of the splint. To assure successful completion of this station, remember to take or verbalize infection control precautions. Prevent the loss of traction at any point after it is assumed. Assess motor and sensory functions and distal circulation before and after splinting. Prevent excessive rotation or extension of the foot after splinting. Be sure to secure the ischial strap before taking mechanical traction. Finally, the final immobilization must support the femur and prevent rotation of the injured leg.
En route, we have an ETA of about 5 minutes.
The most life-threatening complication of major bleeding is hypovolemic shock. The use of the pneumatic anti-shock garment has long been a part of managing shock in the pre-hospital phase of care. Although its use has become controversial, it is important to be familiar with all of the options that are available. The next random skill station that we will review is bleeding wounds and shock. After reading the instructions, the evaluator will read a patient scenario to you. The scene will be safe, and the patient will have a severe arterial bleed in a lower extremity.
Okay, I have my gloves on for universal precautions. I will approach the patient, apply direct pressure to the wound. I will elevate the extremity. At this point, I will ask my assistant to give me some 4x4s and a cling, and I will apply a pressure dressing to the wound.
The principal steps of this station are to take or verbalize infection control precautions, apply direct pressure to the wound, and elevate the extremity. Next, the candidate applied a pressure dressing. When this is completed, the examiner will continue with the scenario.
My pressure dressing is now applied. Did that control the bleeding?
No, the wound continues to bleed.
All right, at that point then, I would reinforce the initial dressing with additional 4x4s and additional cling.
The second dressing does not control the bleeding.
Okay, at that point then, I would apply direct pressure to the femoral pressure point.
At this point, the patient's in compensatory shock. The vital signs are blood pressure 110/70, pulse 118, and respiratory rate 30.
Okay, at this stage then I would ask my assistant to apply oxygen through a non-rebreather at 15 liters per minute. I would elevate both legs, placing the patient in Trendelenburg. Cover my patient to maintain body heat.
At this point, the patient is in profound shock.
The second part of the station is designed to confirm your ability to apply the PASG. Remember to verbalize your actions to assure that the examiner knows that you are completing all the steps. You should be sure to review PASG application in your preparation for the registry exam. To assure successful completion of this station, take or verbalize infection control precautions. Apply a high concentration of oxygen. Remember that a tourniquet is a last resort for hemorrhage control. Control hemorrhage in a timely manner. Inflate the leg sections of the PASG before the abdominal. Reassess vital signs after inflation of the PASG. Make sure the PASG is not inside out when you apply it. Prevent deflation of the PASG after inflation. Finally, do not place the PASG above the level of the lowest rib. Now we will continue with the final 4 random skill stations. The next station is spinal immobilization of the lying patient. This station is designed to evaluate your ability to treat the isolated problem of an unstable spine using a long spinal immobilization device.
Okay. I'll ensure that myself and my assistant have taken universal precautions and are wearing gloves. I'll direct the assistant to please stabilize the cervical spine of the patient and maintain that stabilization throughout the procedure.
In order to pass this station, you must immediately direct manual stabilization of the cervical spine. Maintain manual immobilization of the head until you have ensured that mechanical stabilization is achieved. Assess motor and sensory functions and distal circulation in all extremities.
Check for a pulse.
Size and apply an extrication collar.
Prepare to move, move.
Prepare to move, move.
The evaluator may help you to log roll the patient. After the patient is placed on the board, verbalize that you will check for voids between the torso and board to determine the need for padding.
Before I do that, I will check to make sure that there are no voids in the small of the back, behind the knees, or at the occiput that need to be padded.
Okay.
Completely immobilize the torso to the board before immobilizing the head.
Chest is secured to the board. I will then secure the patient's head.
Okay.
Then immobilize the head in a neutral inline position to prevent excessive movement.
And on this pillow. Thank you.
Then strap the legs to the longboard. The arms should also be secured to the device.
Their pulse.
Finally, reassess motor and sensory functions and distal circulation in all extremities.
Pulse.
To assure successful completion of this station, be sure that you take or verbalize infection control precautions. Immediately direct manual immobilization. Be sure that manual immobilization is maintained until mechanical immobilization is achieved. Keep the head in a neutral inline position. Avoid excessive movement at any time. Finally, assess motor and sensory functions and distal circulation before and after immobilization. The last 3 random skills stations relate to airway, oxygen, and ventilation. We will continue with a review of the oropharyngeal nasopharyngeal airway station. This station is an isolated skills test of your ability to size, insert, and remove OP airways and size and insert NP airways.
First, I start with universal precautions, gloving up. I'm looking at my oropharyngeal airways. I want to choose the correct airway by visualization. I tend to think it may be this one. I want to measure from the corner of the mouth to the angle of the jaw. This looks like it would be the correct one. I want to displace the tongue anteriorly. I want to place the oropharyngeal airway in and revolve 180 degrees, displacing the lip area so that it remains secure.
Your patient is regaining consciousness and is beginning to gag.
In that event, I would remove the oropharyngeal airway completely and make sure that suction is available for the patient.
You need to place a nasopharyngeal airway.
All right, I'm going to visualize and choose one that I feel will be appropriate by its size. I'm going to measure the nasopharyngeal airway from the right nostril to the tip of the earlobe. That appears to be correct. I'm also going to look at the diameter of the nostril as well and make sure the nasopharyngeal airway is a little bit smaller than that. I'm going to lubricate the nasopharyngeal airway. I'm going to have the bevel up against the septum for insertion. Complete insertion.
Thank you.
To successfully complete this station, remember to take or verbalize infection control precautions. Follow proper sizing procedures for these airway adjuncts. Do not push the tongue posteriorly with the OP airway. Verbalize or assure lubrication of the NP airway. Be sure to insert the NP airway into the right nostril. The bevel should face the septum. The next airway oxygen ventilation station we'll review is mouth to mask with supplemental oxygen. It is the intent of this isolated skills test to evaluate your ability to ventilate a patient effectively using a mouth to mask technique.
I have gloves on for universal precautions. They can continue mouth-to-mouth ventilations while I prepare for mouth-to-mask. First, I'll connect the tubing to the tank. Prepare the pocket mask with a one-way valve. Connect the tubing to the mask. Turn the regulator on to 15 liters per minute. Position the airway for ventilations. The tight mask seal and ventilate.
To successfully complete this station, be sure to take or verbalize infection control precautions. After connecting the mask to supplemental oxygen, adjust the flow rate to greater than 10 liters per minute. Maintain a proper mask seal. You must ventilate the patient with no less than 800 milliliters of volume with each breath for at least 30 seconds. Be sure to allow enough time for exhalation between each breath. The last airway oxygen ventilation station is supplemental oxygen administration. This station evaluates your ability to assemble the equipment needed to administer supplemental oxygen correctly in the pre-hospital setting.
First, I'm going to use universal precautions, and I'm going to open the valve on the oxygen tank to clear the tank of any small particle matter that might be in the tank. Next, I will apply the regulator, making sure the O-ring is intact and patent. I've tightened the regulator on, and I will turn the tank on to check for any leaks. There appear to be no leaks, and to check the tank pressure, which is at 1700 psi. I'll now connect the nasal cannula to the regulator and adjust the liter flow to 6 liters per minute. I'm now going to put the nasal cannula on the patient. And the nasal cannula is now on the patient.
Okay, the nasal cannula is in place. I'd like you now to demonstrate the proper technique for changing to a non-rebreather mask.
I'm going to apply the mask to the regulator and set the flow rate at 15. I'm going to fill the reservoir bag completely. The reservoir bag's filled, and I will place the mask on that patient and adjust the straps for a proper fit. The mask is now on the patient.
Okay, I'd like you now to demonstrate the proper technique for discontinuing oxygen therapy.
I'm going to take the non-rebreather off of the patient with the oxygen running. I'm now shutting down the regulator and disconnecting the mask. I'm now shutting the tank off. And I am going to bleed the regulator to clear the regulator of any excess oxygen. And I am complete.
Thank you.
In order to pass this station, you must take or verbalize infection control precautions. Adjust the liter flow for the nasal cannula between 2 and 6 liters per minute. Adjust the liter flow for the non-rebreather mask greater than 10 liters per minute. Assemble the tank and regulator without leaks, and pre-fill the reservoir on the non-rebreather mask. Now that we have reviewed all of the practical stations, let's take a look at the written exam. The National Registry Basic Written Exam consists of 150 multiple choice questions. You are given 2.5 hours to complete the exam. This is plenty of time for most candidates to finish the test. The test questions are derived from the objectives of the National Standard EMT Basic Training Curriculum and are reported in 10 subsections. They are patient handling and transportation, anatomy, physiology, and patient assessment, CPR, breathing, and resuscitation, injuries to the head, neck, chest, abdomen, and genitalia, soft tissue, bleeding, and PASG, medical emergencies, environmental, burns, and hazardous materials, fractures and dislocations, emergency childbirth, and psychological emergencies. In order to pass, you must achieve a minimum overall score of 70%. We have found the following strategies to be helpful. Get a good night's rest before the exam. If you must drive a considerable distance to the test site, consider staying overnight and close to the testing facility. Read the question first. Answer the question in your mind before you look at the answers. Read the questions carefully. Do not read too far into the question. There are no trick questions. However, some may be misinterpreted by the reader. The first time through the exam, do not dwell on questions that present any difficulty. Simply mark them and return after you have finished the remaining questions. Use the time to your advantage. If time remains, review the test. You should only change answers that you're absolutely sure are incorrect. The National Registry has a practical examination user's guide which is offered free of charge to instructors. To obtain a copy, write to the National Registry of EMTs, Post Office Box 29233, Columbus, Ohio 43229. Thanks for joining us in this educational program. We wish you great success on the National Registry exam and in your career in pre-hospital emergency medicine.